So I'm here to give a talk about health equity. Is that coming up? Oh, no, I'm going the wrong way. Oh, is it? There we go. Making the invisible visible, how we are trying to kind of enable using health system data to advance health equity. So I think most people know about CIHI, but I'll just do a bit of a recap and then talk a little bit about CIHI's equity journey, where we're going now in terms of our next phase, really thinking about this as one of our strategic priorities. Talk a little bit about how, as data governance, I have corporate data standards as part of my portfolio. So talking a little bit about how we're a new approach to how we're developing data standards and the engagement around that development. Talk about one of my favorite topics, data stewardship and data governance, and then hopefully be able to wrap it up in time to have some questions. So in terms about who CIHI is, I think hopefully most people in the room do, but we're a not-for-profit organization. We're just wrapping up our 30th birthday party. So we've been around for 30 years and really got set up to really help improve the quality of the health information in Canada. And we've made a lot of progress in the last 30 years. Sometimes it's hard to imagine because we know that there's still so much to do with to manage the data and information and everything in today's world, but we've come a long way compared with where we were 30 years ago. We're funded by Health Canada and the provinces and territories, so truly pan-Canadian. We work closely with everybody in the health system, our federal, provincial, territorial ministries, regional health authorities, hospitals, other health organizations, First Nations, Inuit, Métis partners, to get information across the country and package it and provide it to all different stakeholders to really inform policy, management, care and research. And really our vision is getting better data to make better decisions, which will ultimately lead to healthier Canadians. And sometimes we don't talk a lot about, we talk about all of the data and information that we put out, but obviously there's a huge data foundation across the country that is needed, and so we play a key role in setting some of those data standards, focusing on data quality and the stewardship of the data, and kind of developing some of those core methodologies and information standards like indicators that people are using across the country. So we have a strategic plan, and we always work with stakeholders to figure out what our priorities are and our own assessment of what health information trends and technologies and where we need to go. And for the couple, we've always had some idea of equity being part of that strategic plan. We've had a population health team pretty much since our inception, focused around the social determinants of health and figuring out how to help support the improvement of the population as a whole, given the challenges that we know exist. But really the pandemic, as everyone knows, really shone a bright light on the problems that we know have existed, and that the health and care access, quality and outcomes are not universal. And I'm probably preaching to the choir, singing to the choir here. But we also know we have to measure what we want to change. So unless we're specifically measuring the inequalities in the health and health system, they'll go unnoticed and we won't be able to really tackle them in a systematic way. And during the same time, we had a lot of information about what's happening in the health system itself in terms of the systemic racism and discrimination that exist in for some key populations, including our Indigenous populations and also people of color. And there's a few reports, but there's a lot of information out there around the impacts that this is having on specific populations, our Black populations and other people of color. So I couldn't come to a data analytics conference, although I don't get to play with data very much anymore in my new role. I couldn't come to a data analytics conference without showing some data. So this is from a recent CIHI report that looked at leg amputations amongst diabetes patients in terms of, and done through a bit of an equity lens. So what this one shows is that the people who are living in the lowest income neighborhoods are 3 times as likely to get their legs amputated by that compared with the people who are living in the most affluent neighborhoods, which is the bottom bar. And each of those leg amputations cost $47,000. So there's about 7,000 a year. So if you think about how much that we could save in the health system if the ones in the lowest income neighborhoods had the same health status and be able to do that. And we know, apparently the research shows that about 85% of those limb amputations are preventable. And what really drives the end result in amputations is a trajectory of care. And if things are missed or are not unmet needs up the chain, then that's why people end up having leg amputations. So we know equity impacts can affect all of those across all of those trajectories. So if you think about people who are living with diabetes, if you don't have access to a primary healthcare clinician, then you may have undiagnosed diabetes. If you don't have access to supplementary benefits, you may not be able to get access to the medications you need. Or further down, if you are having complications, some of those specialized services, foot care, all of those kinds of things, all which contribute in the end to unmet needs. So while clinicians are going to be focused on trying to kind of give people the best care they can and deal with those issues, we know even from an efficiency and effectiveness perspective, if we were able to kind of prevent 85% of those limb amputations, that would save $123 million just on the surgeries themselves. And if we could target some of those other issues further up the chain, we could save even more money in the health system. So just talking a little bit about CIHI's health equity journey, and as I mentioned, it started before the pandemic, but has really ramped up since then. And in one of the key things that we did almost 10 years ago now was really hold some consensus information about what the prioritizing the data needs for assessing health equity were. So the ones in bold were the ones that came out of those conversations right now. So those were what we originally focused on. I think some of those have changed and shifted over the years. But we're really trying to focus on what do we really need to help improve the quality of care and the outcomes for some key populations within the health system. Oh, I went too fast, sorry. So we do have already some basic equity data available in CIHI's clinical data sets. So really on the most of it, we have some key ones, age and sex. Well, it's recorded sex or gender because that field is a bit of a mix these days with people being able to update their health card number information on their health card and health insurance information. But we also have, and I think some people mentioned it yesterday, the postal code information really provides a great insight into some of those area-based measures, such as whether you're living in an urban-rural setting, your income, like if you're living in income quintiles in terms of poor and affluent neighborhoods. There are other area-based measures, but those are the two that CIHI uses most often. We have some database-specific examples as well. We talked a little bit about race, and I'll mention it a little bit further on down the road, racialized group. We've had that long-standing in our organ replacement register. We have primary language and use of a translator available in a lot of the inter-eye assessments that are used in specialized areas, including long-term care, mental health, here in Ontario. We added in our national rehab reporting system, there were information about rehab, employment status, because that was really seen when that was developed about 20 years ago as a key enabler to help understand what the rehab needs were. And we did add racialized group and Indigenous identifiers into the DAD and NACA's systems as an optional data field. So I'll talk a little bit more about where we're at right now in terms of collecting and having that information in the system. We also developed a bunch of resources to support equity. So a lot of that historically has been focused, given that CIHI is a data and analytics organization, on analysts to really support the use of equity. So we created a toolkit for measuring health inequalities in terms of how to do some equity analysis. We created a more detailed equity stratifier inventory, so it lists all of CIHI's data holdings and what equity variables are available, and some more information about those key equity stratifiers in terms of what they mean and some of the definitional and things that you need to think about when you're using those in your analysis. And then during COVID, we were working on a race-based and Indigenous identifier data standards, but during COVID, we actually ramped up getting that data standard out, and is now what is baked into the DAD and NACAs and is being implemented in some places across the country. So moving forward, what we're really trying to focus on, and kind of three streams of work that we're working on to advance equity. One is to continue to support the health system in collecting equity data in terms of new data. And that includes the development of pan-Canadian data standards and also supporting jurisdictions and organizations in implementing those data standards, because as I'll talk about, it's not necessarily straightforward, as many of you probably know. We're also trying to think about how that data could flow to CIHI, maybe not in the traditional ways, but in many different ways, depending on how it's being collected. And one of the things we're actually going to be embarking on is actually trying to get a bit of an environmental scan in terms of what is actually happening, because we know there's lots of individual organizations that are moving forward with collecting equity, and we haven't got good insight in terms of what is actually happening across the country right now, given all of the advances. Given the sensitivity of a lot of this equity data, we know we have to think about the governance and responsible use of this information. Oftentimes it's seen as very sensitive information by the patients and the clinicians themselves. So we need to think about how we govern that data, how we think about kind of community governance and incorporating that into how we manage the data flowing through the life cycle. And we're also thinking about kind of within CIHI, kind of how we need to use and analyze the data and continue to evolve and assess the methodologies and the analytical data standards as we're developing reporting products and build those into our systems. And then last but definitely not least, as I mentioned, we have equity standards and equity data in our systems. So how can we leverage the data that we have more? And so some of that is we've done, and I'll show you, we've tended to do ad hoc kind of analytical projects with focus on equity, which are great, but how can we build some of these equity variables into some of our more standard reporting that we provide to our stakeholders so everyone has the information that they need to help manage and improve equity outcomes. And then the other is kind of, can we link CIHI data to other data sources, for example, at StatsCan and others, to actually feed, so we can link, for example, to the census and be able to link data. It's not ideal, given the time lags that can provide, but it can provide some insights that we may not otherwise have, as we're still trying to build the capacity to get the information in the system, because we want to use it for an analytics, but we also know that it's needed within the system itself. Let me just click. All right, so as I mentioned, we're taking a look at what data standards we need within the system. So we're really trying, oh, I went too far, sorry. A new approach to data standards development, and really we're trying to look at it from a very holistic view. As many of you know, CIHI, we're about health system reporting, pan-Canadian standards for comparative analysis. We put a lot of data out to provide those comparative reports. But we know we need to kind of transform the data system so that we can have more efficient data flows through the organization. So we're really trying, as we're working with InfoWay, on how to make the data and systems more interoperable, how we can design data standards that can be used for clinical care and then can flow downstream and more effectively to be then used for all of the different purposes, whether that's within a single organization to help manage operations, again, whether it's a regional health authority ministry or at CIHI to do health system performance, and then for research and other people who are actually looking at kind of global pan-Canadian and local population and public health. We're working, and what that means is kind of we're trying to co-design our systems with a whole bunch of stakeholders, including clinicians and people with lived experience, to get that information into the system. So we are really thinking about responsible collection and use. And really, as we've talked about already, but it's even more so important with health equity data. It requires effective stewardship and governance across the entire data lifecycle, from that design all the way to kind of how we make it available within the system and potentially for research and other people to use it. And data is power. We heard about that. We also heard about the responsibility. I always, whenever I hear with great power comes great responsibility, I have Spider-Man in my head. But I think it's true, and especially with equity data, we know that there is a history of harm and misinterpretation of data. We have heard loud and clear from individuals and communities that they need to and want to have a say and feel they're entitled to have a say in what is collected and how it is shared and used. And I think a phrase that is often used among our Indigenous partners, which is like, nothing about me without me. And I think that applies to lots of different groups, very much so for the Indigenous communities, but also other groups as well. And we also heard this yesterday in terms of the trust is critical to enable the data flows. In lots of instances, the people that we're talking about and want information on, they're very marginalized groups within our societies. They may have an overall lack of trust in our official institutions, and maybe in the healthcare systems they may have suffered racism or feel that they haven't been respected. They may have language barriers, so they feel that they can't get the care that they need. So building that trust at an individual level within the with the care providers and the patients, as well as within the organizational structures themselves, is critical if we really want the data that we feel we need in the system. So one of the things that we have been doing is trying to embed more lived experience into our standards development process. We did this as we developed our race and Indigenous identifier standards, but more recently we are working on our gender, sex, and sexual orientation. So how can we disaggregate that field that we have right now in terms of our what may be collected through a health card number swipe in terms of a mix of sex and gender, to really support gender affirming care, and as if people are going through care that need that level of detail and disaggregation, how can we collect and use that information appropriately? I think particularly it's important as I mentioned, with our change to kind of help support care, clinical care processes, as well as the data that we want from a CIHI perspective in terms of reporting. So we've actually just done some patient engagement on a half-day session with people from the 2S LGBTQ+ community out in Vancouver after a summit that was held, and it was that my manager went to it and she said it was the most difficult but most rewarding thing that she's probably done, because it was, we asked for feedback, we got feedback, it wasn't necessarily all positive. We got a good understanding of how some of the things that we need to do, and I think we have to be able to move forward and make sure that we continue to do this. We're building on work that got started in British Columbia. The Ministry of Health developed their standards. They also did a lot of community engagement around these standards, but it's definitely a journey. And some of the things that we learnt when we did this was really about the importance of creating a safe and inclusive space to be able to have those engagement sessions. We actually partnered with an organization, the Community-Based Research Center, who's seen as a trusted and has a trusted existing relationship with the 2S LGBTQ plus communities. We also had a co-facilitator who is queer, who was part of the community, clinician who works in Manitoba, who was very great because they could also provide that clinical perspective of why this data was important. Not very many clinicians, well, we have a few clinicians who work at CIHI, but that was really important to provide that context. We also had to work, and I don't think we necessarily got it completely right, but really making sure that the information we were providing was in plain language, that the people who we were talking to really understood. A lot of the information we have in the health system is very technical, so trying to make it into plain language was really important, and making sure we have openness and willing to listen. And also that commitment to ongoing engagement. And so this was not just a one and done kind of thing. We have to actually, and are committing to do this on an ongoing basis to really make it successful. And I mentioned kind of as we go through the system, really making kind of continuing to have that view of responsible use. So we need to make sure that if we're going to be sharing this information, we want it to be used, how we can do that so that it's in a trusted way and that it's consistent and inclusive. So there are models that are building around community-based governance, around things that we're trying to look into and make sure that at a pan-Canadian level, we can leverage some of these experiences. So Nova Scotia has their Fair Care project. What they're actually doing is now collecting race-based data as part of the health card renewal process. And they have built in community governance in terms of how they took our pan-Canadian standard and adapted it for their use in Nova Scotia, and then have also set up some governance structures around as the data is going to be used. They're not quite there yet. They're still assessing the data quality, but they're getting to the point where they're going to be able to use it. Manitoba as well, they moved forward with a slightly different approach. They have got race-based data collection, Indigenous identity and ethnicity baked into all of their hospital services systems. That is being managed not by the ministry, but by community, led by Dr. Marsha Anderson at the University of Manitoba, building on lots of great work that they did collecting this information during COVID and managing kind of vaccine rollout amongst Indigenous communities. So if you ever get an opportunity to hear Dr. Anderson speak, it's amazing the work that they're doing. And we know here in Ontario, I know I've talked to a few people in terms of the work moving forward with collecting equity data and needing and are engaging with local communities within hospital networks and things like that. So really, but one of the challenges we're going to face is some of this equity data, as we said, is going to be considered sensitive. So we know it may not be something that's, particularly from a clinical perspective, that will be shared by default, and how we can manage and put requirements in to understand when it should be shared, when it may be need to be protected. And last, we were just talking about everyone coming together and CIHI's partnerships, and in a lot of instances, we're not actually leading the work, others are leading it, and we're trying to help support it. So the Wellesley Institute put a Powering Equity Summit together earlier this year and got everybody together from across the country who were working on race-based data collection, had a great day in terms of that. They actually had a follow-up meeting yesterday, which I couldn't attend because I was here, but I know there's going to be lots of progress in terms of what's going on. Let me just, last but not least, I'll just talk about kind of that possibility of that linked data, so that last column of our strategic plan, and just showing why another example of using data to provide insights. So this is, again, some analysis that we produced from CIHI that came out about our hospital harm indicator, which hopefully lots of people are aware of. But we were able to link our CIHI data through a data sharing agreement with Statistics Canada with the census data. So we were actually able to attach, for those people who filled in the long form census, able to attach some of the equity stratifiers to the DAD records, and we're able to look at a whole bunch of different things. So this one was one that kind of came out from in the headlines, which was around if you don't speak English, you're more likely to get harm. So which speaks to communication challenges and lots of other things that could be driving why people are going to harm. So something that, again, we were talking earlier about what can be actionable, about making data actionable, and I think having some of this insight and disaggregated data can really help drive improvements on the ground in terms of reducing harm and other negative outcomes as well as positive outcomes. So just to finish, I think we're, as I mentioned, one of our strategic priorities is advancing health equity data and reporting. And we know that reducing health equity is really around providing each person kind of that opportunity to be healthy. And reporting is only one piece of the puzzle, but we need to measure things to be able to change them. So this will really hopefully help with addressing and identifying some of those barriers and find opportunities to make progress and then be able to measure that progress as we move forward. So thank you very much. I've got a couple of minutes for questions. Hi.
Hi, thanks very much for the presentation. So I represent an acute provider in this province. I'm sure a few tables here as well. We submit a DAD and NACRS data, obviously, every quarter. Just wanted to understand from maybe an InfoWay or your organization how we could get access, and we are trusted partners. Like, we are submitting our own data to CIHI. So what is the roadmap for like an API or sort of access to this sort of data in a more usable, friendly way? Because I think a lot of folks in this room are probably looking at more modern data platforms, and flat files are just not like the best. And I mean, you can always solution for that, but I think for more modern data sharing capability, that's really, really important. So I just want to ask you, like, what's the sort of roadmap for CIHI?
That's a great question, and we hear you and live that every day. We're actually just embarking on what we're calling our hospital data transformation project. So we are trying to think about a whole bunch of different things with our kind of data NACRS databases, kind of how we can collect the data differently from the hospitals themselves, how the data can flow and be managed and take advantage of all of the new modern ways, but recognizing there is a variety of people at different places, so being where they're at. So we do know that there are still some hospitals documenting on paper and coding and things like that. So we have that whole spectrum, but we're just embarking on that. So you'll be hearing more, I think, about all of that work that we're doing. We're working, as we mentioned, closely with InfoWay to really also think about how data not just needs to come to CIHI, but needs to be shared more generally across the health system, both for clinical care and that system reporting. So more to come on that. So yeah. All right. Excellent. All right. Well, thank you very much.